Should have left off around this slide, page 404 in your textbook. Disorder and disease terms of the cardiovascular system that are not built from word parts. So again, going back to chapter 1, this is our type 2, which is the discussion of terms that are not able to be broken down and separated by the word parts in order to easily know what they mean, but instead just having to sort of memorize them, or again, looking at people's names, eponyms, or acronyms. So we see quite a bit of acronyms here already, and some that we've used on a regular basis in healthcare. So like ACS for acute coronary syndrome. We have patients that come in with ACS pretty frequently. And in a lot of our emergency procedures, we have algorithms in how we're supposed to treat patients in ACS. Everything from giving them oxygen and morphine to start off with, and baby aspirins and things like that, all the way to surgical procedures and stenting the arteries of the heart, in which we'll see examples of that here in just a little bit. A couple others that are here that are common would be like arrhythmia, talking about abnormal rhythms of the heart. Atrial fibrillation, and it says cardiac arrest under it. Atrial fibrillation doesn't always mean cardiac arrest. A lot of patients live with atrial fibrillation, in fact, or AFib. It's pretty common. One thing that it does need to be treated, however, most people just feel like their heart is racing or it's palpitating. You've got this weird sensation of fluttering inside of your chest. Because the atrium aren't pumping blood effectively, then blood sits inside the atrium and just pools there. And as a result of that, it could clot. And then if the heart does go back into a normal rhythm and start pumping blood effectively, it could pump that clot out of the atrium and then into either the pulmonary arteries or into the arterial system. And it can actually be lethal at that point. Some things like coarctation of the aorta. This means like a stricture or a narrowing of the aorta, typically around the arch of the aorta, where it ascends and then it makes an arch before it descends back down into the stomach, or not into the stomach, but behind the stomach into the abdomen. Here's an example of what sort of a pictorial atrial fibrillation looks like. Typically what we see in a normal case is we've got all of these fibers and we have these nodes that you can see here, atrial nodes and then sinoatrial nodes. And what they do is they are connecting to all of these other fibers called Purkinje fibers. And it sends electrical impulses through these fibers. Those fibers are connecting to the myocardial tissue or the muscle, and then that causes a contraction. And then from there, the SA node sends the electrical conduction down through the septal wall of the ventricles and then up around the external wall of the ventricles in order for the ventricles to contract. And based off of the atrial node and the sinoatrial node, that is what keeps the heart in proper rhythm, where you get that do-do, do-do, do-do type of heartbeat and pumps blood effectively. Problem with atrial fibrillation is inside the heart, and all of these little recycle arrows here that I'm coloring in red, those are called irritable sites. And an irritable site is just some area of the muscle tissue that for some reason is causing a problem. It's becoming easily irritable, meaning it will just fire electrical signals for no reason, and it'll just sort of spasm the muscle. And as a result, once one muscle spasms and fires, that electrical conduction goes to the muscle tissue next to it, and then it spasms and fires, but none of them are firing or contracting all at the same time in conjunction with each other. They're all just kind of randomly going off and firing on their own, and that's why we call it atrial fibrillation, because the muscle just sits there and fibrillates instead of actually contracting all at once. So this term down here, ablation, under picture C, is one item, or is one treatment for this. There's also pharmaceutical treatment for it that they'll try to control that with medications. But if that doesn't work, then they'll run this ablation fiber into or a catheter into the superior or inferior vena cavas, and then they will find the irritable site in that muscle tissue, and they will actually burn it. So that's called an ablation, where they actually burn that tissue so that it stops being active. Now, it basically kills that little spot of tissue, so it's not going to be effective muscular anymore, but it's also not going to randomly fire this electrical signal, which then becomes the problem inside of the rest of the heart. And so that fixes the issue. Yeah, maybe you've got a couple of these sites all over the heart where you've ablated them and that muscle tissue is not working anymore, but that's really not a factor when the rest of the muscle is pumping together like it's supposed to. That's called an ablation of atrial fibrillation. An aneurysm, and you probably have heard this term before, an aneurysm means a widening or a pocket of a vessel. A lot of times we hear about neurology, we say like a brain aneurysm, or the patient died from a brain aneurysm. And essentially what that means is that somewhere in the vessel, you've got this widening. So down here in the middle of the abdomen, we can see a aortic aneurysm right here, and it's taking place in the abdomen. So that's actually called an abdominal aortic aneurysm, or a triple A is what we sort of use an acronym. Normally the normal aorta in the abdomen should look like this little offset picture on the right where there is no widening. But where we see this widening here, that's an aneurysm. So that's a ballooning or a weakening or thinning out of that aortic wall. What commonly can happen then is as that aneurysm gets worse, that wall gets thinner and thinner and thinner until finally it ruptures. So if that were to happen in the abdomen, then all of this blood that is being pumped straight from the heart and down here, this is your main garden hose running out of your house. Like your heart is pumping all of its blood through the aorta. And so if this aneurysm ruptures, then it's just going to spill blood just pumping straight out of the heart basically into the abdomen. People have a very low survival rate if an abdominal aneurysm erupts. Thankfully, a lot of times patients will have some symptoms that can lead them to detect an aortic aneurysm early, and then they'll be able to get it repaired and not have it erupt. But very few times if it erupts, are you able to save that patient once it actually erupts. Now, it could be just a very small eruption or just a very small tear of the aneurysm. And so it might not be as severe of bleeding, but that's going to just continue to get worse and worse if we don't treat it. So it's something that is very life-threatening. A lot of times patients in motor vehicle accidents will have their aortas rupture because of the blunt trauma from the force of moving forward and then all of a sudden stopping. And your body, you know, sort of like the car stops, but your body still moves forward. Well, your body's moving forward, but then your body stops, but all of your organs are still moving forward, even once your body stops. And so that thrush on your body can often cause some severe damage and cause an abdominal aortic rupture as well. If this were to happen neurologically, then you get a brain bleed or a brain hemorrhage. And it's similar to signs of a stroke, but in etiology, it's different than a stroke, because in a stroke, you've got a blood clot that's blocking blood flow, whereas in an aneurysm that ruptures, you have a hemorrhage that's actually then bleeding out into the brain. And that can, of course, be life-threatening as well. We mentioned coarctation of the aorta as just being a narrowing of the aorta. And so here you can see that the aorta, and if you've got your left ventricle here, you can outline that. And then your right ventricle is here, outlining that. Your septal wall is this area in between that runs up. And then you've got your right atrium and your left atrium here. Remember, pulmonary artery flows out of the right ventricle, and your aorta runs down here into and flows then from your left ventricle up into your aorta and then out. Now, this is the common location for a coarctation. And you can see it's just like a pinching off or a narrowing of that aorta. So all of our blood flow to our cephalic veins, to the upper body, so our upper extremities and our brain are all getting proper blood flow. Problem is, down below, as this runs behind the heart and then down through the abdomen to the rest of the body, you've got a huge pressure clot type of situation right there where it's really hard to pump that blood through that coarctation, and thus you're not going to have very good perfusion to the rest of the body. That can cause issue with blood flow to your vital organs in your abdomen. which then can lead to necrosis and death as well. Some disease and disorder terms, not built from word parts. We just are continuing this list after looking at a couple of those pictures. A lot of it is kind of straightforward. Hypertension, we've kind of all heard that before. Hypertensive heart disease. This will eventually lead to congestive heart failure due to the prolonged hypertension. Ischemia is a term that just means that the muscle tissue is dying. And so a lot of times we'll say myocardial ischemia, meaning that that tissue in the heart is ischemic or that it's dead. It hasn't had blood flow to it. And so, like, for example, during a heart attack, the patient loses blood flow to part of their heart. The surgeon goes in and reperfuses that and gets blood flow back to that portion of that heart. But part of that tissue remains dead and continues to be dead. It doesn't ever, revive itself or become new again. It just sits there and is dead. And we can actually see that dead tissue then on EKGs and different types of exams when the patient is being evaluated. Mitral valve stenosis. We can actually break some of these words down, and we know stenosis means a narrowing. We've seen that. And then mitral valve, remember mitral ends with L, so that's on the left side between the left atrium and the right ventricle. So a mitral valve stenosis, and we just mentioned myocardial infarction. So a patient may have a muscle tissue infarction where it's not being perfused and therefore that muscle tissue is dying. PAD, or peripheral arterial disease, is something that we regularly see with patients, lower extremity issues where the arterial system is just not sufficient. And then rheumatic heart disease. A lot of patients have valve problems as a result of having rheumatic fever as a child or earlier in life growing up. And so that's something that we'll see on a regular basis. A lot of valve replacements are as a result of rheumatic heart disease due to rheumatic fever growing up. We used the word anemia previously. So like we said, erythrocytopenia, basically commonly known as anemia. Embolus or emboli, meaning a blood clot. Hemophilia is a blood disorder. Leukemia, we know that that's white, and emia meaning less, just like here with anemia. Leukemia would be a white blood cell disorder. And then sepsis is a system-wide blood infection. So a lot of times a normal infection can lead to a septic patient, in which case the infection travels from one part of the body through the bloodstream to another part of the body, and then becomes this sort of system-wide blood infection infecting other parts, and it can be deadly. Lymphatic system terms, Hodgkin's disease or infectious mononucleosis. So the bottom one there, you guys probably all have heard of as mono before. It's that sort of like kissing disease that a lot of high school kids, I guess, get because they're always kissing on each other. But the reason that's the case, it's just a acute infection, but it's transmitted through saliva at a high transmission rate. And so that's why it gets dubbed that kissing disease name, because you've got to sort of swap spit in order to transfer that and get that. Now, that's not obviously the only way that this can be transmitted. Sometimes kids get mono all the time, and it has nothing to do with who they were kissing, but it does have to do with the fact of how it's transmitted. And so that's where it kind of gets its name. The Hodgkin disease is just a cancerous disorder of the lymph tissue. And so again, that's fairly common. We've seen a lot of lymph and lymph node cancers discussed already. Surgical terms for the systems that we're discussing, you can see several of them here. And again, just to kind of point out the recurring plastectomy that we see, centesis, otomies. So again, we've got the cutting, we have the incisions, we have the excisions, the plasties or the surgical reconstructions of, and angio, we know that that was vessel, athero, meaning that plaque buildup. So again, removing or excision of the artherectomy. Endarterectomy, so inside of the artery, removing a plaque buildup. And oftentimes that is referred to based off of which artery is being removed, the most common being the carotid endarterectomy, which your carotid arteries are running from off of your aorta up here and then up to your brain. And your carotid arteries are actually, when we're feeling for a pulse, we're checking the carotid arteries for a pulse on our patient. Those arteries, if they get plugged up and clotted with, well, either a clot or plaque, then that reduces blood flow to your brain, which obviously is a life-threatening issue. So you see quite a few carotid endarterectomies with patients in the cardiovascular intensive care units. This term down here, phlebotomy, break its word down, so it's like a surgical incision of the phleb or of the veins. It sounds fancy and definitely like surgical and very complicated, but literally what we're meaning there is you take a needle, you poke it into the vein, and then blood comes out. Anybody that's at the hospital that's drawing blood is called a phlebotomist, and they're doing phlebotomy. So nothing really groundbreaking surgical about that. However, it is a surgical term. Interesting note about phlebotomy, it is a really good job to get sort of into or get your foot into the door of a medical facility. In Montana, you do not have to have a license to do phlebotomy. There are some states where you do, but in Montana, you don't. The lab will train you to do phlebotomy. I did phlebotomy for about a year and a half when I was in respiratory school. And it's one of the things that really helped me to understand how the hospital worked and all of the different types of healthcare workers in the hospital. And then it also helped me to apply what I was learning in class to the hospital because I could actually see those things being done before I was there for clinic. So if you have the ability to get a position at the hospital while you're going to school, I highly recommend it. It was something that was very helpful to me in my schooling. I worked as a phlebotomist part-time, and then I also worked as an EKG technician part-time doing EKGs. And those two things then helped me to respond to codes because I'd have to go do EKGs on the coded patient or draw blood from the coded patient. But then I was also seeing cardiac patients all of the time that had heart issues. And as a result, I was getting into the ICUs. I even got into the NICU, drawing blood and doing things like that. So it really kind of took someone that if you don't have a medical license or a lot of experience, it's a way to build that experience and see a lot of the different areas of the hospital. So it's one of those areas that I do recommend. The lymphatic system, again, same type of surgical terms, nothing new there, but just applying it to like the spleen and the thymus, so the organs of the lymphatic system. Some terms not built from word parts, cardiovascular system. Here we see that ablation again for atrial fibrillation, coronary artery bypass graft, or known as a CABG. So sometimes we refer to our cardiac ICU as the CABG patch because that's where all of our CABG patients are being recovered. And I think I've got a picture of what that is going to look like. So I'll show you that in just a little bit. And then a coronary stent. So again, looking at the coronary artery and stenting it open in order to reintroduce blood flow to that area. Embolectomy, the excision of an embolus or a clot. Femoral popliteal bypass, very similar to what a coronary artery bypass looks like. So these two are very closely related. It's just happening in a different part of the body. So femoral is referring to your femur, and popliteal is referring to the area behind your kneecap. So the back side of your kneecap where your leg bends, you can reach underneath your leg and feel that. There's arteries back there, and they commonly become occluded with plaque. If that happens, it's basically reducing blood flow to your lower extremity and causing pain and ischemia, and can ultimately lead to amputation if it's not corrected. And so they'll do a femoropopliteal bypass, in which case they will do a graft just like in the coronary arteries, and they'll bypass that fempop artery in order to restore blood flow. Implantable defibrillator device. This is just to help people who commonly go into arrhythmias or go into like cardiac arrest, where it's implanted and it'll actually shock the patient in order to put them back into a normal rhythm, but it's all internal to their body. And so here's that picture of the coronary artery bypass graft. What they're showing here by that arrow is that there is a blockage in this coronary artery, and they're showing like this little yellow plaque built up right inside of it. When that happens, nothing downstream from that blockage is going to get any blood flow. So it's not going to be perfused. And therefore, this whole area of the heart that's being perfused by that artery is going to become ischemic or stop working. It doesn't get blood, so it stops pumping, that tissue dies, and it's unable to then repump. If that goes on long enough, that whole part of the heart will die and the patient will die because this part of the heart is no longer pumping blood. And if that doesn't pump blood, it doesn't matter if the rest of the heart's working or not, it's not getting blood to pump because it's all stopping right there. Thus, the crucial importance of fixing that issue. And you can see what they've done here is they took an artery or a vein from a different part of the body. A lot of the times that they take it from the mammary vein, and then they will stitch it into the aorta, and then they'll stitch it into downstream of where this block is at. And then blood flow is then going to be restored to this part of the heart, and it'll flow back to this part of the heart as well, and then restore that flow. So that's a coronary artery bypass graft. Oftentimes they'll harvest these veins from, like I said, mammary veins, or also some of your leg veins. You'll see they'll strip veins from your calves and then place them up here in your chest in order to reperfuse the heart. So that's a coronary artery bypass graft. A stent is what we'll try to do before a bypass. So the bypass is kind of like, okay, there's nothing else we can do for you. We've got to do this opening up and replace the vessel. But a stent is what we would try to do first, and we'd go to what's called the cath lab or the catheterization lab, because you'll use a catheter and you'll run the catheter up through the femoral artery in the groin, and then up through the aorta, and then into the heart, into the coronary arteries. And they'll run this catheter in there. The catheter's basically got a balloon that's covered by what we call a stent. Stent is kind of like a culvert in that it's going to hold open the rest of that vessel and allow blood to flow through it, but it's going to add some firmness and rigidity to that vessel, and it's going to keep it open. So the problem is we've got all this plaque built up in here. But as we inflate the balloon, it kind of smashes that plaque and reopens the artery. But if we don't do something to keep it held open, it's just going to close back down. So that's where the stent pops open with the balloon, but then when they deflate the balloon, the stent stays popped open. And then it remains in place, it lodges in there so it can't move, and then blood flow is now restored to the rest of the body. There is also what's called angioplasty, in which sometimes they'll try to do the same maneuver, but without the stent. And they'll simply use a balloon to try to pop this open, and then they'll just leave it without stenting it. But oftentimes angioplasties will have to come back in to have it redone several times, or to eventually have a stent placed. There's an example of that on page 415. They show just the balloon angioplasty taking place. And they also show in figures B and C there, they show you that arteriogram of the coronary artery in B when there is a blockage, and you can see the arrow listed there. And then they show you in picture C what it looks like after that blockage has been removed. And you can actually see now there are vessels below where that arrow was, because they've now opened it back up. This is a picture of that implantable cardiac defibrillator, or the ICD device. This gets implanted under the skin. You can see this bulging out of the patient's chest when you're taking care of them. It's oftentimes good to know that that's there. If not, you'll see it pretty obviously. But then it just sends wires down through the superior vena cava, one into the atrium and then one into the ventricle near the septum. That way, if the heart does start to code, then this is going to shoot an electrical signal into it in order to sort of restart the heart or reset the heart. The whole point of shocking a heart is to clear out all of the improper electrical conduction that's taking place and allow the normal conduction of the heart to start up again. Some blood terms, not built from the word parts, talking about bone marrow aspiration, bone marrow biopsy, and bone marrow transplants. Most people have heard about bone marrow issues at some point. This is what it looks like. Typically, they like to use the pelvis because it's a nice, big, thick bone. You can also draw it off of like the femur as well. You're essentially sticking a huge needle into the bone and pulling marrow out of it. which is, it's pretty gruesome, no doubt about it, definitely painful. It is a way to pull bone marrow out for bone marrow transplants in patients that have bone marrow cancer. Another interesting aspect about this emergency medicine wise is we can take needles, and they're called interosseous. And so just like this person's doing, we'll stick a needle into one of the large bones of the body, and then we'll connect an IV to it. And we can run medications or fluids into that IV directly into that bone. And that is interosseous, so inside the bone. That is allowing us to get some medications and fluids into the body through this bone marrow structure system. And it actually provides a way for our patients to be cared for when we can't get vascular access. Diagnostic imaging of the cardiovascular system. There's a lot of cardiovascular imaging that goes into place. We've talked about catheters already, but the arteriograms, venograms, and then of course the scopes, vessel scopes, angioscopes. And we saw some of those on page 415. Because the coronary arteries are so important, and really all of our blood vessels are really important for fusing the body, we need to be able to take a look at them and see where the problems exist within them. And so in doing so, we see a lot of diagnostic imaging related to the cardiovascular system. I've mentioned EKGs before, or electrocardiograms. ECG or EKG, it doesn't matter how you say it. Both of them are proper. EKG is more European. ECG would be more American, but we say both in the hospital here. No one is consistent with one or the other. Kind of depends. You say it how you see it written, and then you'll find you use one particular form of it versus another. The echocardiogram, this would be like using ultrasound in order to actually view the chambers of the heart. And what's neat about that is you can actually see the blood flow pumping through it in real time. And so you can see what rate the blood flow is pumping through the heart and the different areas of the heart in order to identify if there's any issues with that area of the heart. This is what an EKG or an ECG looks like. So this is your typical QRS tracing. You'll see it on ambulances all the time, or now everyone's got stickers on the back of the window that shows like a little EKG, and then it makes a little heart, and then it keeps going. And so it's being used for all kinds of things, but this is what a normal sinus rhythm EKG would look like. And in school, you would learn what each individual little blip here means. So you've got like your P waves, and then you've got your QRS wave, the big tall one, and then you've got your T wave at the end. And you'd learn what each one of those meant, as well as you'd see when you have abnormal rhythms, you would learn what all of the tracings mean there. But really what this is doing is showing you how the electricity is flowing through the heart. So on the previous image, we saw the heart and its electrical conduction flowing through it sort of in this direction. But really there's that node here and there's that node here, and it kind of just stems over and then runs through and then up. But this tracing, all of the ECGs are telling you is how is the electricity flowing through the heart. So you've got an area of the heart that's dead. If you've got this big section here that's infarcted or ischemic, then you're going to see that conduction drop out on the ECG. So you can actually detect old myocardial infarctions on an EKG. Some more diagnostic terms. These are not built from word parts. Cardiovascular system. Here we see some angiography. The digital subtraction angiography just means we're removing a portion of the background. I think there's a picture of that on page 422. They actually are showing an angiogram of the patient's brain. And so in picture A there on the left-hand side of page 422, you see all of the bone structures as well as the vessels. But then in digital subtraction, you actually remove that background of it. So it's almost like a green screen or chroma key effect, similar to how I've got Bozeman in my background and some nice mountains. It's basically using similar technology to remove all of the distracting artifacts so you can just look at the vessels. Doppler ultrasound, again, just another type of ultrasound test so that we can look at the vessels to see how patent they are and if there's good fluid flow through those. And then exercise stress test. Sometimes a patient will have cardiac symptoms, but then they come into the hospital and everything checks out just fine. And then they go home and a few weeks later, they have those symptoms again. They come into the hospital, everything checks out fine. So at that point, the physician is going to order them to have a stress test. The stress test basically then meaning we're going to stress your heart to the point where it starts to show us what's wrong with it. So they'll push it with exercise to the point where it starts to fail, and then they'll say, that's the problem right there, now we know what to fix. They can also do that chemically with different types of material in order to make the heart chemically stressed, even though we're not exercising physically in order to do that. We mentioned a TEE prior, a transesophageal echocardiogram, and with the TEE, we're basically just sending a probe down through the esophagus, and we're going through the esophageal wall to look at the heart. So coming down into the chest and just looking transesophageal through the esophagus, doing an echo through the esophagus. That gives us a different view of the heart. It lets us look from the backside of the heart, as opposed to always just looking at this one top view of the heart, and allows us to see blood flow of different parts of the heart and from a different perspective. We talked about catheterization already, impedance plethysmography. It's kind of difficult to explain, but it's using infrared and red light on alternating patterns, and then also using pulsatile blood flow in order to learn different things about what's inside of the blood and what's going on. So I'm not going to go into a whole lot of detail on that just because it takes a lot of detail and don't want to get into the weeds on it. Some other diagnostic terms that are a little bit more familiar, cardiovascular wise, blood pressure and sphygmomanometer. Sphygmomanometer is just the blood pressure gauge that we're using to measure the blood pressure. And then of course, pulse, we mentioned before. Pulse is just every time your heart beats, we feel that pulse in pressure in our arterial system. So here's a picture of the sphygmomanometer. They really don't show a good picture of it. This is the cuff, and here's the bulb that they're pushing air into the cuff. But the actual manometer part is back here, which you cannot see. So they did a really poor job about this in this picture, because the cuff itself is not the manometer. The manometer is the gauge that actually has the needle that shows you what the blood pressure is. Some laboratory values: C-reactive protein, CPK, CBMK, which is not listed here, troponin. These are all enzymes of some sort that when muscle tissue starts to be infarcted or starts to lose perfusion, it starts leaching off these enzymes, which is indicative and diagnostic to us for heart attacks, ischemia, or other types of skeletal muscle failure. But depending on which type of this enzyme or laboratory value that we're seeing, depending on when it elevates and for how long it elevates, can be very specific to myocardial tissue. Coagulation time is how long blood takes to clot. And so we talked about atrial fibrillation before, and the fact that if that blood is sitting inside of the heart, it could start to clot and then become a problem. Likewise, if you cut your finger, how long does it take for it to clot? On patients that are in AFib that just we cannot get them to stop fibrillating, we'll put them on an anticoagulant, or what we would term as a blood thinner. And that basically just ruins the ability for the platelets to clot. It makes the blood cells really slippery so that they won't clot. That's good for an AFib patient because that means they're not going to clot and throw that clot into their pulmonary artery. But with those patients, you also have to keep in mind when we're drawing their blood, they're going to bleed out a lot longer. So we need to hold pressure for a longer period of time before we just tape it over with a Band-Aid. And then also, if they cut their fingers at home, they need to know, like, you're going to bleed for a couple minutes instead of just a few moments and then it clots off. So it's important for patients to understand that. These are often the patients that you'll see, you'll look at their arms or their legs and they're just bruised all over the place because someone drew their blood and then just put a Band-Aid with a cotton ball on it and then walked away. And yet the blood is still bleeding into their tissue underneath their skin. And that's why they've got these huge bruises or hematomas afterwards. Some complementary terms for the cardiovascular system: atrioventricular, AV, so that just refers to both the atrium and the ventricles. Obviously, cardiac is pretty straightforward since it's cardiovascular system dealing with the heart. Cardiogenic, again, genic comes from that base word of genesis, so something that's starting in the heart. So we would say cardiogenic pulmonary edema would be fluid that is filling up the lungs, so edema in the lungs, but its cause is from the heart, so it's cardiogenic. Its genesis is the heart, and that results in fluid building up inside the lungs. A couple other words here referring to blood. So heme is that word root for blood. And so hematologist, hematology, the physician and the study of the blood, poiesis or generation of new blood, hemolysis, which would be lysing the blood or destruction of a blood vessel due to a lysing of it. Stasis is static, so no blood flow or blood is just pooling in one area. So if you've got blood pooling in your ankles, for example, you have that edema down there, that's a hemostasis. But we also would say that, have we achieved hemostasis, like with a post-op patient, meaning have they stopped bleeding on the inside yet? Is that hemostasis? Bruit is a common term referred to like when you're feeling a patient's pulse and you kind of feel this vibration in their pulse. That's known as a bruit, and we'll oftentimes feel that in patients with different types of cardiovascular abnormalities, especially when they have a valve issue in their heart. CPR, pretty straightforward, cardiopulmonary resuscitation. That includes chest compressions and rescue breathing for the patient if they do have a cardio or pulmonary arrest. It is possible for a patient to only pulmonary arrest. They can stop breathing, but yet still have a heartbeat. Now, that is short-lived. You can only not breathe for so long before your heart stops as well. If a patient's heart stops, all blood flow stops, and that patient is not going to be breathing. Just kind of some things there. The CPR, the cardio, and the pulmonary go hand in hand the most part, but it's usually one or the other that's causing the problem. Defibrillation, which we'll take a look at here in just a minute, is that electrical resetting of the electrical balance inside of the heart in order to stop an abnormal rhythm or to try to kick into a normal rhythm. So here is the traditional, and this is on page 434. This is sort of that traditional picture where you see the person with the two paddles and they slam them on the chest and, you know, and the patient gets shocked. And that's not really how we do it in the hospital, not anymore. We don't use paddles. Like, there are paddles still, like if you're in the operating room, you might see some paddles, and then we also have some internal paddles in case the chest is already open. We can set paddles in and go right onto the surface of the heart, but those are more like rods than they are paddles. And what we do now, though, is we take patches, and so we have patches that come over and we place them with adhesive onto the chest in these areas where these paddles are being shown. And then that is going to, once we deliver the shock, is going to do the same thing as paddles do, but it allows us to leave those patches on and not to be in contact with the patient at all. And so then what it does is it shoots this electricity at high voltage through the heart, and it gives you a flat line of the heart for a moment. And if you've got like normally we saw that EKG here on that previous slide where it kind of looked like this. Okay, so normally that's what our heartbeat is going to look like. But if instead our heartbeat's looking like this, we're calling that fibrillation, in which the heart's just going like crazy, fluttering or fibrillating, but it's not actually pumping any blood. It's just spasming back and forth a ton. So in order to stop that, we send this huge shock through the heart, and it basically causes then a flat line of the heart so that that fibrillation will stop. And then once it stops, that SA node that is the normal conduction piece of the cardiovascular system should then kick back to providing a normal rhythm. Sometimes that works, sometimes it doesn't. It kind of depends on what the cause of that, our atrial or ventricular fibrillation was in the first place. That's what defibrillation looks like from a code perspective. It's a part of CPR that takes place, but is sort of like its own separate component to CPR.
I have a question.
Yeah, go ahead.
We've had people like come through the ER who's had like serious AFib, and we've shocked them.
Yes.
I haven't really experienced it hands-on. Are they awake?
Yes, sort of. So if we're gonna defibrillate, and that's what we would be like, this is that emergency shock, like for a patient who's coding. Typically, we used to use 360 joules worth of energy to defibrillate a patient. And that's when it was just monophasic, meaning it goes in one direction. Now our technology goes in one direction, but then it also comes back the other direction and sort of like like shocks it in both directions to get a complete baseline. So now we're only using like 200 joules of energy in order to do a biphasic shock. When someone comes in with atrial fibrillation, we're using the same type of shocking, but we call it a cardioversion instead of like a shock. Now we might still refer to it, okay, let's shock them or whatever. Well, typically we'll say we're going to cardiovert that patient. And oftentimes we'll start with a patient at like 60 joules in order to cardiovert them out of atrial fibrillation. But it's the same idea. If you can flatline that atrium and get it to stop throwing those weird signals, then it can start back up and convert to a normal sinus rhythm. That's what's happening with those patients. Because we're using such a small amount of electricity, if we have time, if it's not life-threatening, then we will sedate that patient mildly. We call it moderate sedation or conscious sedation, in which case, if I were to like really pinch them, they would respond, like they would be appropriate, they would respond to pain, but they're gonna kind of be loopy. They're not gonna really remember what's going on, but they're still gonna be conscious. So we'll support their breathing, but they still will be breathing on their own, and then we'll shock them. And then as soon as we shock them, they're just like, and then they're back all of a sudden. And usually they say just the most bizarre things coming out of the shock. It's actually funny in some situations if it's not a life-threatening situation. But that's what's going on with those patients. Now, if we don't have time, like they are critically symptomatic because of this atrial fibrillation, then we will actually not sedate them and just do straight cardioversion without sedation, which is not comfortable for the patient, but it's absolutely necessary. But we try not to do that if possible. So some cardiovascular terms not built from word parts. Usually here, some of them have the word parts that we're used to, but just sort of combined with or used in ways that we're not. So something like a murmur, like that's obviously not a word that we're used to, but a murmur, also when there's a problem with a valve, just like when we saw with the bruit, we can see an issue and we can actually hear a murmur with our stethoscopes and know that there's a problem with one of the valves. Occlusion just means an obstruction or a blockage of some sort. I used the term systole earlier. There's also diastole. Systole is when the heart pumps, and diastole is when the heart relaxes. And then we see a few of these other terms using lipids, which are just fats. It's a term for fat, and so hyperlipidemia, increased fats in the system. Hypertension, increased blood pressure. Tension just means pressure. Triglycerides, again, that's just another type of fat descriptor. Vasodilator, dilation means to open up or expand, and vaso meaning the veins. So vasodilator, or not veins necessarily, arterioles too, but just vessels. And then venipuncture would be putting a needle into the venous system. Anticoagulants, we used that term previously when we were talking about AFib and blood clotting. Hemorrhage, we use that term as well when we were talking about the cerebral hemorrhages, or when patients are going to be bleeding out of their vessel, which of course can cause a major issue because the blood's not going where it's supposed to go, but instead it's going where it's not supposed to go. Some of the immune system words, a lot of them have the word immune in them because they're the study of the immune system, but then we see a lot of allergens and like antibodies and antigens, referring to dealing with the allergen or the issue that's causing the allergy. And then anaphylaxis is an important word because that's a word that is when you have an allergic reaction that is life-threatening, then we term that as an anaphylaxis. And sometimes we see patients' airways swell closed, we see their eyes swell closed, their tongues can swell massively and cause major breathing problems for those patients. Then leaving off, of course, with our lists of abbreviations. We've talked about a lot of these already, so I'm not going to go through any of these, but there are a handful of them. So that will conclude class for today.